Hello and welcome to Medical Surgical Nursing 1, Module 4, Altered Neurological Functions. Here you will find our goal statement, our module description, and the objectives for this lesson. I will also do a lecture on Tuesday on this topic, but this is to help us with our lecture on Tuesday. It's a supplemental to the lecture on Tuesday. So let's get started on our first objective, and that is describe the neurological assessment of the patient. Let's look at this short 2-minute or so video regarding the central nervous system.
Did you know that the most important part of your entire body is your central nervous system? Your central nervous system, also known as the master system, is made up of your brain and your spinal cord, and it controls every single function in your entire body. In fact, your central nervous system is so important that it's the only body part that is totally encased in bone for its protection. Starting at the top is your brain. And your brain is the central processing unit of your body, and it coordinates and computes all the electrical signals that are sent throughout your nervous system and your entire body. So from your brain, electrical impulses or signals are sent down your spinal cord and travel all the way to the base of your spine. And branching off of your spinal cord are these fine thread-like structures called spinal nerves, and they exit between the vertebrae of the spinal column to supply all your muscles, cells, and organs, and from there, the electrical impulses are sent back up to the brain in a feedback loop. And at every level in your spine, the exiting spinal nerves supply specific muscles and organs. For instance, starting from your lower back, these spinal nerves supply such structures as your legs, reproductive organs, bladder, kidneys, and colon. As we move up the spine to the upper back or thoracic spine, the exiting spinal nerves supply such organs as your liver, stomach, heart, and lungs. Moving up further to your neck, these nerves supply such structures as your eyes, ears, throat, and arms. Now, in a healthy spine, your spinal bones or vertebrae are in proper alignment, and the cushioning or shock absorbers between the vertebrae, called intervertebral discs, are thick and healthy. As such, correct spinal movement is possible, and the spinal nerves are able to freely exit the spine, sending nerve impulses from the brain to the targeted muscles and organs without any interference. However, from poor posture, falls, a car accident, or some other injury, your vertebrae can become misaligned. This misalignment is what chiropractors call vertebral subluxation complex, or just subluxation. When a subluxation occurs, your vertebrae can then press on these existing spinal nerves and interfere and block these nerve impulses. When this happens, nerve damage begins and your body starts to dysfunction. Although potentially painless at first, symptoms can develop rapidly. And when a subluxation is left untreated, your spine begins to decay. Your discs begin to thin and wear down, and your vertebrae start to deform and degenerate, leading to the development of these spurs or osteophytes, which then further compresses and damages your nerves. So when a subluxation occurs in your lower back, it can cause back pain, sciatica, bladder weakness, irritable bowel syndrome, and erectile dysfunction. A subluxation in your upper back can cause respiratory problems, digestive problems, and decreased energy levels. And subluxations in your neck can cause headaches, dizziness, tinnitus, carpal tunnel syndrome, numbness, tingling, and weakness to one or both of your arms. Fortunately, chiropractic can help. In fact, chiropractors are the only healthcare professionals that are specifically and adequately trained to detect and correct vertebral subluxations. And through a series of precise chiropractic adjustments, your chiropractor will restore your spine's proper alignment, remove nerve interference, and return your body to its optimal health. And it's important to note, your body has the ability to heal itself, so long as there is no interference. So, having a healthy spine is not just about removing pain and symptoms, but achieving your body's maximum health potential.
That was a good video. I want to refer you back to your medical surgical book, chapter 42, and I want to remind you guys about your anatomy and physiology class. Review your anatomy and physiology, the nerve system, so everything can make sense for you. I'm just going to scroll through this little section. This is very important. And this is like a quick synopsis of your anatomy and physiology that you had in the past. But it's important for us to focus as nurses on the neurological assessment. So we will start with that. And first, I'd like to go to page 841. And here we go. First, let's learn about what is normal. Let's get the normal down first. So let's just gear in towards the normal. Now with our brain, you had a picture of the brain earlier, and I have some slides for you too. But look what happens in the frontal lobe. Primary motor area, also known as motor strip or cortex. Look what happens. Your Broca's speech center. Voluntary eye movement. You guys know when you're doing your assessment with your cranial nerves, now start bringing that assessment into your neural assessment. Voluntary eye movement, access to current sensory data, access to past information. So now when we're having patients with neurological problems, now we can put that picture better together and figure out, oh my goodness, they're having an effective response to a situation, or their behavior, this regulates in the front lobe your behavior, and they start having all these, they had some kind of brain trauma, they having these behaviors or judgment problems or problems with long-term memory. You're going to bring that together and say, oh my goodness, this patient is probably having frontal lobe problems, and maybe the injuries in the frontal lobe area. The same thing going for your parietal lobe, understanding the sensory inputs such as texture, size, shape, three-dimensional perception, needing for singing, playing. So when these things changes in the patient's behavior that pertains to this area, you wonder what is going on, where possibly could be happening to that patient. And also look at the temporal lobe, what's going on in the temporal lobe, auditory center. And then look at the occipital lobe, the vision. I'm having blurry vision. I got hit behind my head. I can't see, things like that. So I want you guys to start putting that bigger picture together. As we move on, table 41-2 talks about the brain stem function. You can read this on your own, but I want to point out down here. So it says the circulation in the brain originates from the carotid and vertebral arteries. Now we're going to speak further about different occlusions that can happen in the brain and different things that can happen, but I want you to get familiar with the internal carotid arteries branch into anterior cerebral arteries. You might hear a physician, healthcare provider say ACA, and the middle cerebral artery, MCA. Very important to know. Of course, these are the largest arteries too. I want you to know that. Please keep reading on, and let's keep going on. I want to make sure you understand. You might hear somebody say, right MCA, left MCA, and I want you to go, oh, they're talking about middle cerebral artery. And when you go, oh my goodness, when they're talking about right, where is that? So then you go up here, and you look in your book, and you can see what a middle cerebral artery is. Okay, so I want you just to get an idea. There's not going to be a graph for me to point out these things to you in a test and so forth, but I want you to pay attention to where these arteries are so we can understand how they affect our body and how we can assess our patients. I wanted to speak on the Glasgow-Coma scale. I put 2 scales here, and there's also one in your book, but this is the one that's more familiar to you in your book. Just know that the highest possible score is 15, so that you will add the very first. Patient open their eyes, motor response, they able to follow commands, and then the verbal response, they're oriented. So that would be 6 plus 4 plus 5, which would give them 15. The lower the score, the decreased neurological assessment that they have. So you don't want like you're here, say GCS for Glasgow-Coma scale, GCS of 10 or a GCS of 6. That means these patients are very ill, they're not responding, something neurologically is impaired, and these are very sick individuals. The GCS scale is also considered a standard rapid neurological assessment tool. So it's also found in figure 41-9 on page 850. I'm sure that you guys are all aware of the neuro assessment, so let's begin some more. You're aware of asking your patient if they're alert and oriented to person, place, and time, and reason for admission, or you can say event. Either or is acceptable. Make sure that you are staying tuned into your patient and making sure you see or ask them if they're blind in one eye or the other, or both, or if they're hard of hearing in both ears or one or the other, so we can put those devices in to help them. Let's go back to the Glasgow Coma Scale and look at this NCLEX question. Can you answer it? Now, with the Glasgow Coma Scale, have your book open and look at the chart. So it says here, the nurse is assessing a client who opens both eyes when spoken to. So you look at your Glasgow Coma Scale where it says eye opening spontaneously. So they open their eyes, so they get a 4. Obeys command. So you go under motor response and you're going to see obeys command and they get a number 6. So that's 10. And then it says seems confused during conversation. So you go under verbal response where it says confused conversation, they get a 4. So now you can see 6 and 4 was 10, plus 4 is 14, and you have the letter B there. I hope we all added up and got the same answer. Moving forward in our physical assessment and that area that most people leave blank for GCS, now I want you to start including your GCS in your patient assessment. Please include your GCS score in all of your patient's assessment moving forward. Now with your assessment, I want you to bring in all the cranial nerves that you remembered and bring them into your neurological assessment. So remember our olfactory, optic, oculomotor, trochlear, trigeminal, Dussen's, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. You guys have already remembered these. Now I need you to start applying them. So you're going to apply them to your assessment. You've been doing this already, so I know that you got this.
The Glasgow Coma Scale is often referred to as a patient's GCS score. There are 3 main areas of assessment that comprise the score. Thus, the lowest score you can give a patient is a 3, and that score is reserved for patients who are dead or in a coma. The highest score a patient can get is a 15, and this is a score that the majority of your patients will have when you go in and assess them. Eyes are the first area that you assess. They can rate from a 1 to a 4. If a patient is able to open their eyes when you come into the room, then they get a 4. If they keep falling asleep when you stop talking, or in the middle of them talking to you, then they just get a 3. If they won't open their eyes when you talk to them, but will open them to a sternal rub, give them a 2. If they don't budge for anything, then you just give them a 1. The next thing you're going to assess on a patient's GCS is their verbal response, which is rated from 1 to 5. If the patient is oriented to person, place, time, and situation, you give them a 5. If they're talking to you but they think that it's 1984, then they get a 4 to denote their confusion, but you give them a nice high 5 for picking such an awesome year. If they keep asking for a glass of bird or would like to eat some remote controls, you give them a 3 for inappropriate words. If they make no noises but no words come out and they're not an infant, then you just give them a 2. No verbal response gets a 1. The last thing you assess in the GCS is the motor response from a 1 to a 6. Patients who follow commands get a 6. A 5 is for patients who can feel and react to localized pain. 4 is reserved for people whose only purposeful movement is away from pain. 3 is for decorticate posturing. 2 is for decerebrate posturing. And you guessed it, you give a 1 to those who show no response.
I thought I'd add that short video to make it more clear on how to assess for the Glasgow Coma Scale. We will continue on. This is part 1 of module 4, and continue on to look for part 2 of module 4, and we will start with nursing focus on the older adult, the changes in the nervous system relating to aging. Thank you, and I'll see you for part 2.